Thank you, Raisa, for giving me the opportunity and Anjali madam. So, actually, our topic is prevention of corneal blindness, the current perspectives. So, corneal opacities affect 1.9 million people. It's about 5.1% of the total population of the blind people. The importance of corneal blindness is that it usually affects more younger population compared to other major cause of blindness like cataract, glaucoma, and the age-related macular degeneration. And this actually leads to more economical problems, more problems to the community. So, what are the reasons for corneal blindness? The most common one are infections like bacterial, fungal, viral keratitis. Other infections like trachoma, onchocerciasis, leprosy, ophthalmia and nutritional like vitamin A deficiency, inflammatory conditions like Morans and Steven-Johnson syndrome, other dystrophies, degenerative conditions, trauma lead to corneal any epithelial defect or aberration that leads to microbial keratitis, or be a penetrating trauma or a chemical injury, or can be a pseudophakic bullous keratopathy. So, if you look at the causes, you can see most of these diseases are more common in poor socio-economic classes. And this blindness is also more in these patients because one thing is the delayed presentation. So, whenever there is an injury or trauma, patient will be symptomatic, but they may not present you in early time if the patient has a poor economic status. Second one, usage of traditional medicine. We all know usage of over-the-counter medicine and traditional medicine for this epithelial defect or injury. They will not be putting any antibiotic prophylaxis, etc. Third one, absence of microbiology. There will not be any gram stain or any KOH media or culture media. In countries like India, we have about 40 to 50% of the infection is because of the fungus. And delayed in diagnosis and treating it as a bacterial cause may leads to a deep infection and a large infection which cannot be treated easily. Also, inadequate treatment because of the patient's economic status. They cannot afford the medicine. They cannot keep the medicine in the refrigeration if you give them some reconstituted medicine. And that also leads to blindness. So when you think about prevention, we have primary, secondary, and tertiary prevention. So primary prevention, as we know, actions or intervention taken to prevent the onset of disease. Secondary prevention, the measures we can treat the disease and prevent development of the visual disability. And tertiary prevention, that means how we can restore the vision of the patient. So first step should be address overall causes as we discussed, like infections, nutritional deficiency, or address the reasons, aim to understand the problems in the community and build their existing knowledge and know about the knowledge in the skills in the community. Like primary prevention, we have other programs or problems like vitamin A deficiency, measles, that can be prevented with the proper vaccines and nutritional programs and vitamin A supplementation programs. Ophthalmia neonatal can be prevented with the usage of topical antibiotics or topical antiseptics that can be available in the hospitals, that can be also available with the all midwives. Trachoma, we have particular program, we have safe strategy. Eye injuries can be prevented with suitable spectacles. They have to warn the professions like welders or farmers who are usually exposure to these injuries. Second one, strengthen the health system with programs as we Rachel Madam discussed with measles immunization, perinatal care, nutrition, water supply, sanitation. All these have a major impact in the community health that can leads to a better eye health and prevention of blindness. And we have to collaborate with the existing health workers force and teach all health workers to diagnose and refer the corneal pathology early. Teach them the importance of antibiotic prophylaxis in newborns and all corneal injuries. We can introduce the eye health promoting posters, videos, seminars. Also, in our country, we know the firework injuries are very common, and we have to use the advertisements, media, social media to decrease the fireworks related injuries to the cornea and eyeball. In secondary prevention, as we know, all these corneal diseases are usually very symptomatic. So they usually approach healthcare persons, but the usage of self-medicine and alternative medicine can lead to a devastating complications. You have to educate this patient and teach the other specialty doctors to refer these corneal pathologies early. Then, when we talk about the tertiary prevention, we know most of these corneal opacities can be treated with a keratoplasty. But the problem is that only 40% of the bilateral corneal blindness is estimated to be treatable with keratoplasty. Why? Because most of these patients have associated glaucoma, retinal diseases, corneal vascularization, poor ocular surface, especially in chemical injury, Stevens-Johnson syndrome. So but there are mass majority like 60% is there. We have to train the ophthalmologist for corneal transplantation. Increase the number of eye banks. This should be our priority in tertiary prevention of corneal blindness. So in a last study of keratoplasty in Nepal, it showed that the most biggest predictor of the success of the keratoplasty is the distance of the patient lived from the tertiary eye care center. Why? Because when you do a keratoplasty, a beautiful clear cornea, that can end up in a rejection or failure if it is not clearly monitored or followed up. So all these patients should have a accessible to ophthalmologist, and all ophthalmologists should know how to early identify a rejection, how to treat the rejection, how to do the follow up for these patients. So that should be included in our curriculum. Also, that should be included in our programs. And also we know, even though number of corneal surgeons are more now, but they are doing less number of keratoplasty. One thing is lack of access of tissue, cost of the tissue, and poor institutional support in many centers for the corneal surgeon for a keratoplasty program, and inadequate surgical instrumentations, cost of the instruments like trephine. Sometimes, as we discussed, there are low number of qualified comprehensive ophthalmologists to share pre and post-operative management of the keratoplasty patients. So, which is actually the most important prerequisite for the long-term success of the graft. So we know graft success outcome for a long term is very less in India compared to the developed countries. It is because of the follow-up of these patients for glaucoma or rejection or failure that can be early detected and treated successfully. And an increase in the cataract surgery rate actually leads to an increase in the corneal transplantation rate. Why? Because when we have more number of cataract surgery, the government programs, government training, etc., will be more concentrated towards the other specialties like transplantation, retinal diseases, etc. Therefore, it is a good thing that our CSR rate, cataract surgery rate, is improving. It was like 4,600 in the 2005, and it's gradually increasing very rapidly thanks to our programs. Nowadays, our TPS, our transplantation rate is like 16 or 17, which is very low and is gradually increasing nowadays. Also, the usage of tissue, even though we have so many eye banks, our it's only 30 to 35% of the tissues are utilized. But compared to the major eye banks, which have a well structured organization, they are utilizing like 70 to 80% of the tissues. So that should also be strengthened. Usage of the procured tissue should be maximum. Thank you for careful listening.